right. Thanks, Mark. I think every single slide you showed that the suture button technique is superior. So, all right. So, thank you. All right. So we're going to look at the Syndesmosis suture button implant, and really, is this a new gold standard? These slides aren't advancing now, so I'm already like a minute in my talk. So. There you go. I am an arthritis consultant. I do not receive royalties on this product. So the big debate is, should we be using screws or suture button? Why use a suture button? Well, it's double the strength of a 4.5 millimeter screw and cyclical loading to failure, avoids the need for removal, and allows micromotion for collagen healing, which, as we saw with the ankle instability, is really helpful. Note on this is a busy slide, but there's a sagittal translation as well as external rotation of about 4.3 degrees. So if you're using screws, you're not seeing any of this normal syndesmotic motion. And if you've paid any attention to the sports headlines, you've seen that Alabama has an epidemic of quarterbacks going down with syndesmotic injuries. Tua first, and then Jalen Hurts, and then Tua again this year. So, and I did have I was privileged to see those images on at least Tua's first ankle injury, and he absolutely needed surgery just to make certain that Norm's a good friend of mine, and he provided me actually with this video here. This is a lineman who's only 10 days out from surgery and already starting to play. At 12 days, he passed a 15-leg hop test, and then we can see here he is, number 76, playing right tackle here, 2 weeks out playing in a game, so pretty extraordinary. Post-op guidelines, splint for 4 days, anti-inflammatories, transition these patients into a cam boot, PT, range of motion, weight bearing is tolerated, swelling control or edema control with a game ready, begin running at 2 to 3 weeks, cutting initiated as tolerated, and return to play. 2 weeks is very aggressive, I will say that, but 4 to 6 weeks I think is reasonable. This is a simple device to implant, unlike what Dr. Easley just showed. This is the newest generation of this device by Arthrex, and you can see you can simply pull back on this little handle. There's a little button there. I usually put a finger over that, and I just did it in this video under fluoro so you can see, and I just push that button flat on the tibia, and it works out pretty nicely 100% of the time. Let's look at the evidence now of screw versus suture button. First, we'll look at functional outcomes. American Journal of Sports Medicine, 2018. This is a meta-analysis study. Suture button was better than screw, and with postoperative scores statistically significant. Lower rate of broken screws, lower implant removal rate, lower rate of mel reduction. So definitely better in that study. Journal of Orthopedic Trauma, 2015. Suture button fixation achieved better clinical performance at 3, 6, and 12 months. They conclude that tightrope offers adequate stabilization without failure, and reoperation rate is significantly lower. Another meta-analysis study published in 2017, 10 studies, 390 patients, slightly higher AOFA scores in the suture button group, but lower implant removal rate, failure, and mel reduction, all statistically significant. And then lower complication rates in this study, looking strictly at the knotless suture button device. Complication rate was lower in the knotless suture button, and return to sport was quicker, 14 weeks versus 19 weeks, which was statistically significant. Accuracy of reduction. Are we able to reduce the syndesmosis accurately with screw fixation? This study isn't a comparison study. This just looked at screw fixation of the syndesmosis. 25 patients with an ankle fracture and syndesmosis instability with screw fixation, and what they determined was we really aren't very good at determining reduction in the operating room with fluoro. 24 of these patients postoperatively had evidence of x-ray diastasis, and 52% had incongruently on their CT scan. Their conclusion was many mel-reduced syndesmosis were not seen on plain x-rays but were noted on CT. Here's another study that actually prospectively looked at the two groups, and they had 22% mel reduction in the screw group and 0 mel reductions in the suture button group. More evidence that states that we're probably doing a better job of reducing these with suture buttons. And then this debate comes up, should we use 1 versus 2 suture buttons? What's better? There's some theory, at least, that says in a bigger or a sports athlete that we want to get back out on the field, maybe using 2 suture buttons makes sense. What's the evidence for this? Well, Tom Clanton looked at this in the lab, and no technique restored the ankle to the intact model. All techniques resulted in very posterior sagittal translation with external rotation stress. But he did conclude that 2 suture buttons may be better than 1. Now, Norm Waldrop looked at this in Birmingham, Alabama. He's concluded that all 3 techniques of syndesmotic fixation were equivalent in providing stability to the torn syndesmosis, but 1 suture button versus 2 parallel suture buttons versus 2 divergent suture buttons, really there was no statistical significance, so he questioned the need for a second suture button unless there's extenuating circumstances. So there's this last construct that I would like to just mention, and this may be the future of syndesmotic fixation. This is a single suture button with ligament-specific repair, namely of the AI-TFL, and could this construct lead to improved functional outcomes and more closely parallel the intact model? So this group out of Japan, suture button fixation, with suture tape augmentation achieved dynamic stability similar to the intact model. They looked at all different constructs, including screws, 2 tight ropes, 1 tight rope, and what they finally came up with was this construct right here was probably the best. And they concluded that screw fixation was too tight. I've gone to using this in my athletes, so for a syndesmotic injury, and I'm glad Greg alluded to this. So this athlete, we went medially, we fixed his deltoid with what I call a modified Brostrom medial repair with 2 suture anchors medially, and then went laterally, fixed his syndesmosis with a 2 suture button technique, and fixed the AI-TFL with suture tape augmentation. So in summary, the suture button's becoming the new gold standard for syndesmotic fixation, stronger constructs, resist diastasis, does not require removal, quicker return to work in sports, with better functional outcomes versus screws, and when combined with suture tape augmentation, may approach the intact ankle model in regard to physiologic motion. Thank you.